Hello, everyone, and welcome again from Singapore. This is session 11 of the SingLive 2022, and it's a great privilege to be here together with my fellow panelists. So what we will be doing today is we're going to be presenting the last live case of the day from National Heart Centre in Singapore, and it promises to be quite different from the cases that you have seen over the course of today. So we're going to be performing a complex PCI in chronic kidney disease. So let me quickly introduce my co-chair as well as my fellow panelists. So my co-chair really needs very little introduction. It's Prof. Eberhard Grube, our good friend here in Singapore, and he's got friends all over the world, as you know. So Prof. Grube works out of Germany, but he's well-traveled and well-respected and really a friend of, like I said, everyone across the world. We also have Dr. Himanshu Gupta. So Professor Himanshu is now working out of the Postgraduate Institute of Medical Education and Research in Chandigarh in India. We have Professor Junji Yajima. He is the hospital director of the Cardiovascular Institute based in Minato in Japan. So welcome, Dr. Yajima. We have Dr. Praveen Chandra, who is also a dear friend of SingLive. He is, of course, chairman of interventional cardiology at the Medanta Medicity in India. We have Professor Huay Cheem, internationally renowned professor of cardiology and medicine, who is based out of the National University Heart Centre here in Singapore. And then last but not least, we have Professor Yuji Hamazaki, also another dear friend of SingLive. We miss him very much. He is director with the Division of Cardiology out at Ota Konomori Hospital in Japan. And coordinating the chat for us today is Dr. Yong Thon Hon, who is a dear friend. He works out of the cath lab in Changi General Hospital here in Singapore. So I think we are still waiting for the cath lab at the Heart Centre. But before, while we wait to cut over to them, let me just try and set the scene here. So we're going to be looking at a patient with chronic kidney disease and discussing the kind of considerations for PCI in this subgroup of patients. So maybe I can invite Prof. Grube. What are some of the things that go through your mind, some of the considerations when you're told about a patient with CKD going for PCI like this?
Yeah, obviously it is important to note that in chronic kidney disease, we have a very sick patient, and we have to be as careful as possible using contrast because it obviously is not good for the kidneys. So this will be an interesting approach to see how they can deal with the disease. I assume it is just more than one vessel. It is probably a 3-vessel disease or diffuse disease, as we see often in chronic kidney disease. Another thing that comes into my mind in chronic kidney disease, we have usually calcified lesions. So we have to deal with calcifications. Diffuse calcifications in these patients. It is altogether, as far as coronary heart disease and chronic disease concerned, it is usually quite a challenge because it's diffuse, calcified in all 3 vessels. So it's going to be very interesting how they approach this, whether they do a complete or try to complete revasc, or they do some focal, most severe, in order to save some contrast.
Yeah, okay, that pretty much summarizes the case, I think. I think I've just received note that the cath lab is ready, so let's cut across to the cath lab at Heart Centre. Okay, so the operators for today are Professor Jack Tan, a good friend of mine and head of Department of Cardiology at the Heart Centre, and with him is Dr. Muhammad bin Idu Jion, who is also a dear friend. He's also a consultant interventional cardiologist. So Jack, I think you know the entire panel, all waiting to hear your case and how you're going to tackle this.
Actually, it's quite timely. I heard Eberhard's comments, beautiful comments, and this is exactly the case that he expected. So I think we'll jump into the case, we'll show the panel the case. I do need some advice because I'm not too sure what I need to do at the moment. Idu, can you present the case?
Maybe please? I can present the case. Can we show the slides? So our gentleman is a 75-year-old Indian gentleman with the cardiac risk factors of hypertension, dyslipidemia, diabetes, a family history of ischemic heart disease. He was an ex-smoker and he has advanced CKD 3B. He first presented in January last year with heart failure. At that time, his ejection fraction was 40% with global hypokinesia. He declined coronary angiography then because of CIN risk. However, later in the year, he presented with NSTEMI in November. And this time around, he had a MIBI scan to re-stratify. And that showed there was ischemia plus transient ischemic dilatation, which is suggestive of severe triple vessel disease. He agreed for coronary angiography, and CAF showed a triple vessel disease. He was seen by the surgeons. However, he declined coronary artery bypass surgery. So PCI was actually done in November to the LAD with one stent and to the RCA with two stents. At that point in time, it was done with low contrast and with about 60 mils of contrast use. Next slide. This is his baseline ECG. Next slide. So his EGFR was 36, but actually as of today, his creatinine actually is higher than 171. It's actually 200 today, and his EGFR now is actually 28. Okay, next slide. These are his current medications. And let's show the previous angiogram. So this was the angiogram of the left coronaries before the PCI. Next. And then this is after showing the PCI on the LAD done. And then this was the right after the PCI. His Euro score is 4.7. Syntax 2 is 44.7. Next. His CIN risk on the Maron score of 20 is about 57% CIN risk and 12% risk of dialysis. So we need to be careful with our contrast use. Next. So in summary, we have a 75-year-old gentleman with a host of cardiac risk factors. The key tip of which is the advanced kidney disease, and with recent NSTEMI in November, and our target today is the circumflex. Over to you, Jack.
So thanks, Lord Chitang. So you see, this is a typical patient that Eberhard was alluding to, fairly aged with diabetes, calcified vessels, mildly impaired EF, with an EGFR initially starting with 36. But in spite of the very due diligence and care pre and post hydration, 60 mils of contrast with intervention to the right and LD guided by IVUS, his creatinine has climbed to 200 odd within a space of 4 weeks. His EGFR has dropped further to 30 or less, around 30 mils per minute. And now we're looking at this circumflex OM1 lesion as a last lesion to complete the revascularization. And we really want to keep the contrast down. As you know, I think the ballpark figure is that we shouldn't use more than 30 mils of contrast for this particular intervention. We do know that if we give him more, he has dipped into CIN. His CIN risk is at least 50% if you go anywhere close to above 30 mils of contrast. So I'm not too sure whether you can see the previous circumflex angiogram on the slides, but perhaps I can get some guidance from the panel. Or would you like me to show you what I've done so far?
Yeah, did you take any shots today? Did you use up some of your 30 mils already?
So maybe I can just quickly show you and then narrate my preference at the moment. Then maybe you can let me know from the panel what you guys think. So I think because of the fact that the creatinine went up, I favored using a femoral approach. So that's one point of discussion because I see his trajectory is some form of dialysis in the future. I'm not too sure when. So we want to preserve his radial artery. I went femoral, ultrasound guided puncture. I used 1 mil of contrast to shoot a subtraction angiogram to make sure that we can close this groin properly. So a bit faint, but it's 1 mil of contrast on the subtraction mode. It was without any further contrast here. The groin was a bit tortuous, a bit difficult to engage with a EBU 375 guider. In this case, I elected to use a side hole catheter. His groin was a bit tortuous and difficult to engage. But we put in IVUS catheter just to take a look at the LED prior stent because I'm not going to shoot any dye into the left system or the LED at the moment. and also to help me look at the proximal edge of the previous stent. And true enough, it was parked beautifully. We can show that later, right at the ostium of the LED. So I shouldn't have much problem crossing into the circumflex. So this is a sequence showing, and I elected to use subsequently a FFR system using the Boston Comet 2 system. I'm trying to see whether there's any artery I didn't have to do. So I use DFR to adjudicate the values in OM1 and then subsequently OM2. And finally, I use a microcatheter, and you can see this shot. So this is a 2 mils injection localized through a guide liner at the proximal circumflex into the circumflex, and without shooting any more further dye into the LED. So far 3 mils contrast down. And I just like to share with you the IVUS findings at the moment. Can we go to quickly the first run? So this is a first run of the IVUS showing the ostial positioning of the LED stents. You can see it's right at the ostium of the LED. The stent looks pretty well expanded. It's a 3.5 by 28 stent. Pretty decent. There's a lot of calcification around it, but no edge dissection, and we stopped there. Then the second run, please. The next one. Sorry, I don't have much angiogram to show you guys. This is the IVUS run coming back from OM2 back to proximal LED. Right at the distal circ bifurcation, there's a normal landing zone. And then it's quite diffusely diseased. And as you pull back, you can see that actually there's disease proximally, and there's a segment where it seems to be fairly concentric calcification somewhere around here. Just at and before, yeah, somewhere here, at and before the bifurcation and after the bifurcation of the OM1. So fairly calcified lesion. The length of the normal to normal segment is around 38.5. The distal reference diameter is around 3.0. Proximally is at least easily a 3.5 vessel. Then we tried to have a look at OM1, but OM1, the IVUS catheter can't really pass very well. This is pulling back from OM1. You can see that there is a lesion there, which you can see on angiogram. And the catheter, however, can't cross, and I didn't want to push it. So one last piece of information, Chee Tang, is that because we use the FFR, I'd like to tell you the values now of the DFR, which is equivalent to IFR on the Boston system. So OM1 had a value of DFR 0.8. What was it? Yeah, first one?
8.1.
0.85 for DFR, and FFR of 0.81. That's OM1. And surprisingly, when I put in the distal OM2 distal circ, the DFR value was 0.91 and FFR was like 0.93 and 0.91. So it's not significant, but clearly there's a lot of lesions there. I think maybe spurious in my mind. Chee Tang, so now I've given you some information. My strategy is to keep it simple because I really don't want to use more contrast.
Jack, maybe before you reveal your strategy, maybe we can get a bit of an opinion from the rest of the panel. So I think very elegantly already narrated there by Jack. So maybe some comments, Dr. Praveen, you agree with what's been done so far, or any other suggestions?
Yeah. So, it is absolutely important to know from the previous intervention as to what happened after the contrast, which was, I think they gave 60 ml of contrast, and creatinine increased or not. And if it has increased, generally it is imperative to give a cooling off period of about maybe 6 weeks before you do the second intervention. So that is what we practice most of the times. And certainly, as he has already told, that the rule is that we use the amount of contrast is to be the same as the GFR. So here the GFR is 30, so he has chosen to take 30 ml. And as far as the femoral artery puncture is concerned, I could have saved maybe 2 ml contrast there by doing ultrasound guided compression maybe. So that is the only thing which I would like to do that. And certainly, not using a side hole guiding catheter will be my choice. And also, I would like to take a 6-French guiding catheter here, not a 7-French, because that will push more contrast. So these are the small steps which I do when I want to save contrast. And as he's already showed, IVUS is the way to go. And we do IVUS in such cases. And some patients, what I do is I do a saline contrast OCT, because many times it is not very clear. Once we have put the stent, and if you want to really see whether the stent edges are good or not, I do a saline contrast, and that shows the edges and the expansion very well. So I pretty much what he is doing, I would be doing, but additionally I try to do these steps.
Dr. Hamazaki, you have quite a lot of experience with advanced kidney disease patients in Japan. What is the strategy much different in Japan?
No, not so big difference. So, and of course, we can use image modality. So we always use image modality, and I check the IVUS in this case. And we often use IVUS guidance, stenting and ballooning, and etc. And in this case, guiding extension is used to reduce contrast media. And of course, I often use this manner. And in addition, I often use chip injection from a microcatheter. And it is one option to reduce contrast media. Okay.
Fantastic points. Yeah. Prof. Tan, you have something to...
so maybe I just give some comments to Jack case. Well, this is a patient who has actually the major territory revascularized already. So he's actually left with left circumflex, which probably is the smallest territory. And I assume that he's asymptomatic. And so we have to sort of ask ourselves whether we want to risk jeopardizing his kidney further in doing a revascularization procedure. So that's the first thing I would say. The second comment is I do agree with Praveen. In somebody who's got a rising creatinine, you really want to not add further insult if you can, and wait for some kind of stabilizations before you do any further intervention. Then thirdly, you now have the functional physiologic information to tell me that actually I don't really have to deal with this case today and hurt him further. So my take here is that I probably will treat him medically for now, because I just don't see any sort of advantage in revascularizing.
Yeah, no, those are great points. Actually, I think
that's an interesting point that Huay Cheem is mentioning. I think that's an interesting perspective, because we always get caught a little bit in between doing something that seems to be obvious and then maybe not do something that is not really necessary. I'm a little bit doubtful. I agree with him that, the most territories are being taken care of. I haven't seen, quite frankly, the circumflex and the OM lesions quite well. So I assume the fact that we're doing this today, it is quite significant. I have to say, the OM is significant. Whether this vessel is a big one or is serving a great territory, I don't know. But I would be very careful, and I kind of follow Huay Cheem's advice to weigh carefully whether to proceed or not, given the kidney situation.
Yeah, I think there's something in the chat about the FFR, because as Huay Cheem has very correctly pointed out, it's so-called not significant when measured in the distal circ. But there was some observation that was this done with the guide liner inside the in the artery, Jack? Because the proximal waveform looked a little bit ventricularized. That was the comment in the chat.
Oh, okay. It was without the guide liner. The guide liner is just for the single shots to delineate the artery. So perhaps it wasn't very clear on the limited shots that we did, but the pre-angiogram, it was a tight lesion there. And the IVUS clearly showed a very calcified concentric lesion in the circ. So there is a lesion, and I do agree that the FLR findings suggest that there is ischemic. I also agree that we try to not cause further harm to the patient by giving more contrast. And therefore, my slant is to keep the intervention as straightforward as possible in this case. I am in favor of just treating the proximal to mid-circ into the OM2 and leaving the OM1 alone, and optimize it with intravascular imaging and not further make it complex. His intervention, the first one, was exactly 6 weeks ago, actually. It was in early November. So if I may, I already marked out the territory. I've done some pre-dilatation. Can I show you the latest run on IVUS after the intervention, Joyce?
Yep, sounds good.
Jack, can I ask you a question?
Yes, Eberhard.
I think the interesting part is the IVUS and the OCT situation here. I assume that you've done the IVUS, and you're not using OCT. Is that correct?
No, I'm not using OCT. I'm using IVUS, which I think you can see the IVUS here. And this is after a 2.5 mm NC Scorflex intervention and a 275 NC balloon. So there's an area of very hard calcification that have 2 cracks achieved. The initially was quite wrapped around. So there is actually a tight lesion there. And I think to keep it simple and taking out the comments, I truly don't want to make it a complex intervention, particularly in a CERT where the other 2 major territories are revascularized. So I think the trick, taking out the comments, the trick is to really minimize harm by not giving more contrast. And I want to keep the intervention as straightforward as possible in this elderly patient with CKD. So
maybe I can ask Dr. Yajima. Sorry, Jack. So, Dr. Yajima, what do you think of the IVUS results after this pre-dilatation? Do you think enough crack in the calcium, or we need to do a bit more?
After the balloon dilatation, I recognize the 2 cut. But not enough dilatation. So I recommend another bigger balloon. Recommend. So.
Thank you.
Thanks, Yajima. That's very good comments. So I'm a bit wary of too high pressure balloon where I'm limiting my contrast. I saw the cracks and the balloon actually expanded very well on angiogram, fluoroscopy grab. So I am quite comfortable to implant the stent with that result rather than going with a larger balloon and I can't check for dissection. So especially in the CERT. So I marked out like what Professor Hamazaki suggested, the proximal and 2.5 Scorflex NC followed by 275 NC.
Okay.
And what stent size?
I'm a bit wary about going on to a 3.5.
Right.
I'm
what
marking
stent size is it?
To the distal normal. So this is 3.0 by 40. I marked out the normal segment at distal reference was 3.0, but proximally was 3.5 and above actually. So
can we see the angio in the main? Can we see the angio in the main screen, please? Yep, thank you.
Okay, can you switch back to angio? So I have marked it previously using the IVUS for the proximal segment. So I just want to make sure I'm closer to negative, please. And then go up here.
So Jack, I see this concentric lesion of about 2 millimeter diameter. Where is it located? Like the ostium, is it? Or
no, it's just right after the OM1 bifurcation. 9 nominal. Down.
It looks okay, actually.
Yeah, that looks not bad.
So then I'm going to go in and do a properly sized posterior balloon and port across the bifurcation. 3.5, please, NC.
So Jack, any tips? How do you do this IVUS marking? Do you use any other landmarks? Are you using the bony landmarks? Or any other tips and tricks here?
Go up here. So I try to stay 9, 10. So I try not to move the fluoro anymore, down. And I would mark out where the proximal landing zone is. I'll do a cine shot. And there is a osteo LED stent as well as a marking wire in the OM2. So I have actually fluoro captured where the proximal marker of the normal segment is, and I know exactly the length is around 38.5. So if I position it at the proximal marker, it should cover normal.
There is a.
So now I'm going to do a post migration.
So I don't know if you have the possibility of doing a IVA score registration here, because now I think we do it very routinely. If you have taken only one shot, you can do a IVA score registration, and that gives a very accurate assessment of the positioning of the stent and the length of the stent. Everything can be assessed.
That's also a very good point. Our IVA score registration system is with the Volcano system, and currently we're using the Boston one.
Mm-hmm.
So in this case, we chose to use a Create Trio by 40 with distal markers. So it makes it easier, a little bit easier, I think, to mark out. So the proximal stent probably is not very well expanded. The NC balloon can't really cross as well. Even with the joke balloon.
So, Chee Tang, just for the purpose of discussion, if you do a lesion preparation with circumscribe the calcifications, what are your steps in lesion preparation? What would you recommend?
I'm sorry, Eberhard, could you say that again? Sorry, it just
if you have just for the purpose of discussion, when you have a circular calcified lesion, to do a lesion preparation, what would be your steps? Would it be starting with a balloon, then a cutting balloon, then shock wave or something? What is your strategy at the National Heart Center?
Yeah, so I think actually we have a variety of opinions with regard to this. My personal practice is always to try a little bit with the balloon first and see how it responds. And I think if I had that result that Jack had, I probably would have done as Dr. Yajima mentioned, be encouraged by it and then go in there with a bigger balloon. But if there was totally no give, then I think very low threshold to move on to something like a IVL, just to get that shattering of the calcium.
Yeah.
Himanshu, you're doing quite a bit of calcium work in India. What's it like in India now?
Yeah, Prof. So similarly, thank you for the question. If it's a concentric calcium, like in this case, then the balloon-based technologies work quite well. So I would generally start with a non-compliant balloon, and if it does not work, put in an IVUS again, see if the calcium appears thick and there is no give, then move on to an IVL. But generally, focal circumferential calcium lesions generally go with a balloon. So you don't need an IVL unless it's a very long. But if it's a protruding calcium and the wire bias is favorable, then I will generally go for a rotablator and then assess further with imaging. But generally, focal lesions balloon works well. Yeah, Prof. In my opinion, Prof.
Can you come back, please?
So, Prof, I wanted to add.
So there's a question on the chat actually, and maybe Dr. Praveen can help us with this. So do you have a preferred peri-procedural hydration strategy for patients such as this, EGFR about 30? Do you think it matters, or do you have kind of
certainly? Yeah, I think this is very, very important, because the only thing which is helping a patient while we are doing intervention is hydration. And I don't think we have data of anything else making any big impact. So we always hydrate these patients for at least overnight. If patients are admitted in the hospital, it is reasonable to start overnight hydration intravenous and then take the patient early in the morning, like the first case, then taking as the last case. And also, if the patient is admitted on the same day, we give at least for 4 to 6 hours of IV hydration and then bring the patient on table and then continue hydration for the next 6 to 8 hours. So that is our usual strategy. And that generally, I think, is, most of us do that.
Eberhard, do they do any different in Europe?
No, we do it exactly the same way. I think hydration is the only good thing we can do.
Yeah. So Jack, what's happening now? Yeah, sorry. Yeah, go ahead.
Yeah, we'll go
Jack,
to
what's
Dr.
happening
Jack.
now?
I can't quite catch you. Was there a question, Chee?
No, I think Himanshu wanted to ask something, is it? Yeah.
No,
Go ahead, Himanshu.
I was just saying that in these CKD patients the contrast-induced nephropathy, the contrast is important, but also the peri-procedural hemodynamics. Sometimes a long procedure doing the LED, RCA, or a left main, if they have hypotension on table or a slow flow in any vessel, that can also, irrespective of the amount of contrast used, they may also put these patients into a risk of CIN. So having adequate hemoglobin, hydration, short procedure, no hemodynamic compromise, all of these in combination are actually required to prevent the CIN.
Sorry, Jack, what size is this now? Is this still the 3.5 or are you doing a different size here?
This is a 3.5 NC balloon.
Okay.
So I'm really trying to get it very well expanded before we repeat the IRIS run. Stem boost again. So you can see the create has this stand edge marker that I'm trying to position.
Yeah. So Dr. Hamazaki, can I ask you, in this kind of almost zero contrast procedure, if the balloon is oversized and really there's a perforation, how can we detect it before the patient becomes hemodynamically unstable?
Of course, I don't want to use the oversized balloon. So we decide the balloon size according to IVAS findings. So perforation risk can reduce. Okay.
Nitro, please.
Yeah, so I think that just proves the point that this kind of procedure is almost impossible to do without intravascular imaging. I think it would be quite foolhardy to go in there. And, I think you can get away with some quick POBA and put a stent in.
In such a situation, I avoid the oversized dilatation. I use a atherectomy device before ballooning and stenting. So maybe in this case, as you can see, this case has circular calcium. So maybe in this case, I use atherectomy device, maybe OAS in this case.
Right.
So,
can I ask
is that something you would consider, Richard?
Well, OAS is reasonable, but you have just increased the level of complexity of the procedure which we are trying to avoid. So I think in this case, rotablator is out because the lumen is too old, so the bird is not going to touch anything. IVL is actually a good option. But I will actually go with the earlier comment, go for the balloon first, and then if the balloon doesn't overcome, then IVL will be the next strategy here, just to keep the whole procedure again safe.
Right.
And can I ask a question to Dr. Jack? Prof? Yeah, Prof, the distal circumflex, the lumen was 3 millimeters. So you were just using a 3.5 millimeter balloon distal to the OM. Is the OM at that point also a 3.5 vessel, just distal to the first OM, Prof, the circumflex?
It was quite calcified, so the true vessel size is quite difficult to tell, but I usually just use the same 3.5, but I use it as a lower pressure. So I expanded it with a 3.5 NC, but at 8 hemispheres, very close to the distal send H, and then approximately closer to 16, 18. So this is the result that you see after the 3.5 NC balloon optimization. Coming close to, this is a spot where previously it was concentrically calcified. It's not too bad. It looks expanded.
Very good expansion.
Yeah. Almost 7 millimeters here, 7.5.
Still a bit eccentric, but I wouldn't try too aggressive. It's already a post. So this is coming to the, go ahead.
Although you could still have a build-out IVL even after implanting a stent with suboptimal results, but this has been done many times, but still not advisable, but anyhow, you still have a backup option.
Yep. I saw that actually the stand is fairly well expanded. Maybe I can show you again. Can you on the iris? On iris manual, please.
Dr. Yajima, are you satisfied with this iris appearance, you think, or
record?
A bit more work needs to be done? Sorry, I think you're muted.
Sorry, this result is very good. So enough dilatation. So, but this case, case's calcium is not full moon. So I think this case is not necessary to ablation device. So, but if this case there is a full moon calcium, I recommend the ablation device before stenting.
Okay.
But this is not full moon calcium, so.
Yeah.
Comment, please.
Following the least aggressive and least complex philosophy, I think fine-tuning and doing a little bit here, doing a little bit there, I don't really think it's necessary. From what I can see, I think I would be very happy with the IVUS result. Suppose there's no dissection or no downstream problem. It was beautifully done and keeps the procedure straightforward and simple, if I may say, given the complexity of the case.
Absolutely.
Yeah, the enemy of good is perfection. Eh? My only concern now is whether Jack can pull back the OM1 guide wire. This is flat in the calcified. High pressure.
Okay. I just crossed the lesion with the FFR comment wire, but I'm going to just pull back and just quickly re-zero again, just in case there's a drift. Can you? Is it possible to re-zero? Re-equalize? The trap wire is a feeder wire, so I'm quite confident I should be able to pull back hard enough. I hope. Okay, so is it?
So Jack, you're planning to do this because you want to decide if you're now going to intervene on the OM or? No,
because previously there was a lesion. Maybe it's again not clear, just proximal to the OM, and I sense that the FFR reading is because of that. And if we can show that even after I potted the IVUS result looks good, then I'm just going to stop here actually. And the OM1 is actually not really significant.
You're not going to repeat the FFR, DFR in the OM1, right?
I'm repeating it now to show that.
That's what you're doing now.
Yeah,
okay.
Yeah, that's what I'm doing now. So can we do the, but it's positive. So I probably have to take a shot and have a look.
Yeah, because there is a likelihood that the ostium may have been some plaque shift or carina shift.
Carina shift, yeah.
So what do you guys think actually is significant?
If it's just an OM, I'd leave it alone.
I would too actually. Yeah. I'm also going to take a shot.
Prof,
I'm going to take out a gel
maybe
wire.
If you are there, just. Yeah.
Wow. Okay.
Sometimes knowing too much is makes things confusing.
Okay.
So right.
Can I
so
have
well said.
Can I have the guide liner, please?
Okay, Jack.
Prof, did you put the circumflex wire in the OM? Did you pull back the circumflex wire and put it in the OM? Is it?
Oh
yeah, that's what he did. He pulled back the comet wire.
Comet wire and then FFR it. Yeah. So we
so
still
Jack,
don't actually have.
Yeah, sorry. We've been told that we can go on a little bit longer, so that would be great. But we are also of course mindful of the time. So you're going to take a shot now, right, with your guide extension, is it?
Yeah, that's right.
Okay, great.
Again, so I will do the injection over a 5 mil syringe and just try to cap the contrast again at just 2 mils, just at the proximal stand edge.
The formula that go by for contrast volume to be used in patients to avoid CIN is a 2.7 multiplied by GFR. So you do have some room to play here.
Although Dr. Praveen has a different threshold. I think he mentioned the number of mils equals GFR, which is quite challenging.
I think that's a very nice formula, which my nephrologist has told me, and I always follow that.
It looks okay. I mean, I don't have DFRIs, but yeah.
I think whatever the number, I sense I will trust the experienced advice. I hear Huay Cheem and Eberhard both telling me it's sometimes better to stop and not overdo this type of cases. I'm also quite happy the result, actually. I've done in total about 5 mils of contrast, including 1 mil on the femoral shot. And
maybe we can go one round of the panel and see what people's opinions are. Jack, is that okay? Dr. Hamazaki, please. Would you, looking at the physiology result in the OM1?
I accept these results. Okay. No
you
problem.
Accept? Yeah.
Yes.
Okay.
Yes.
Dr. Yajima?
From the DFR, I need the KBT.
KBT. That is a good discussion point, actually. Do we need to KBT this kind of,
I mean, in an ideal situation without all this limitation, I would say I would agree with Dr. Yajima, but otherwise, no. Yeah, for this case.
Okay.
Beautiful. Andrew is very good, but the DFR is a little bit small.
Yes. I think Eberhard says it looks beautiful.
I can read between the lines, Eberhard. Thanks for that. I'm going to stop.
This is very nice.
Yeah. Okay. So are you going to take any more shots or you're happy, right?
No, so like the first case, actually, pigtail, please. Actually, my operator previously actually put in a pigtail and used a Poseidon regime to hydrate. And there was exactly a pre-hydration in the prior case and using a LVDP Poseidon regime to post-hydrate. And again, in spite of that, 60 mil of contrast, he did have a CIN impact. So again, we're going to just have a quick look at the EDP, noting that his LVEF is mildly impaired, but hydrate him fully. I think that's the only thing we can do at the moment, although I think a 5 mil contrast impact is quite low for this patient.
Sorry, maybe you can just quickly explain to us what is this Poseidon regime that you're referring to?
Idu, maybe you can talk about it.
So there was a 2014 RCT about pre-hydration where they compared standard hydration versus hydration based on LVDP, and the main cutoffs are between 8 and 13. So if it's less than 8, then you give a 5 mils per kg hydration for 4 hours. Then if it's between 8 to 13, you give a 3 mils per kg per hour for 4 hours. And if it's if the EDP is more than 18, then you just give a 1.5. So that's actually to guide how much fluid regime we're going to give after.
And all these patients had a 2-hour pre-hydration.
Okay.
Can I have the... They all had 30 mils per kilogram pre-hydration.
We have a challenging question from the audience, Jack. Very
then
challenging
you can answer on my behalf then. Can I have a flush? The flush is open.
It's a loaded question.
Yeah,
it is a loaded question.
What was a loaded question?
So if the DFR is negative and PCI was performed, but now with the DFR as positive and we have deferred, what is the
no, so it's actually a fair question. I think initially my idea about using the FFR wire was to gauge whether I need to do XY lesion, whether I need to do the LED or I need to do the OM1, or I can spare it and just make it simple and do the cert. I recognize that the OM1 is positive, but even on retrospect, when I look at the technicalities of it, to use more contrast to do a two-stent strategy, I'm just going to base it on my clinical judgment, and I recognize that there's still residual ischemia in OM1, but for this patient, with everything that's done, my sense that this is more than enough. If I look at the LVDP, what is it? LVDP is already around 16.
So we give 240 mils an hour for 4 hours.
Yeah. So this is a recommended hydration regime post based on EDP.
We'll round up to 250.
Yeah. So, okay.
Okay, Jack.
Okay,
so
I think we've done all the full assessment, and we're stopping here.
Fantastic case. Really, really amazing. 5 mils of contrast, I believe, is what you ended up with. So that's really amazing. Do you have any maybe final tips and tricks with regard to this case before we say good evening to you?
Yeah, my own sense is that I think you hear that the experienced operators are erring on the side of not overdoing. The other part, but the technical bits of the procedure, is that although we say it's minimal contrast, I want to emphasize that minimal contrast means it must not go beyond compromising on safety. So if you do run into any problems, then I think the contrast issue is less of an issue. You truly need to get the patient past the intervention safely. You do need some experience, and you do need some experience, particularly in imaging and doing the imaging assessment properly. The other trick is, of course, try to keep it simple, don't overdo it. And I would be more hesitant on using any form of atractomy devices when you're not using too much contrast. I still prefer some contrast, right, and zero contrast, to have a pre and post shot for medical legal reasons, and not truly stick to zero contrast. Ultimately, this group of patients, the outcome is quite guarded because of the CKD and the multivessel disease nature. So try to do less harm and concentrate on the pre and post procedure hydration. So that's all I have for this patient for teaching points. Thanks, Chee, and back to you and Eberhard.
Thank you, Jack.
Well, thank you very much, Chee and Jack. Under your leadership, we've done a beautiful case. You've done a beautiful case. We've learned a lot. We covered a lot, all aspects of chronic kidney disease and PCI physiology. So thank you very much. Being respectful to time, I think we have everything has been said. Wonderful panel. You had a great leadership here with a great chairman. I'm saying hello from Germany back to Singapore, Japan, and India. Hopefully we see each other soon. Congratulations, Jack and team, for a beautiful case and an excellent result. Thank you very much, and be safe.
Bye.
Thank you, everyone.
Thank you.
See you all tomorrow.
Thank you so much. Yeah.
See you tomorrow.
Bye.